Patients with behavioral health disorders may seek treatment at a hospital without specialized services or staff, particularly via the hospital's emergency department. As commitment to service is a hallmark of America's hospitals and health systems, many organizations are innovating and collaborating with community-based agencies to ensure that the behavioral health needs of their community are met in a timely and effective fashion. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer for AHA. In part 2 of this 3-part series, our speakers will share how Tidelands Health took an existing space down, adjacent to the emergency department in one of their hospitals, and created 6 private rooms for behavioral health patients. This new environment improves safety for patients and staff and provides a calmer environment for assessment than the hospital's emergency department.
This is Rebecca Chickey with the American Hospital Association, Director of our Behavioral Health Services area. And it's my honor today to be interviewing Ashley Capps, who is the AVP of Nursing Operations at Tidelands Health in South Carolina. And Ashley is going to speak to us and help us record today's podcast, which is Addressing the Needs of Behavioral Health, Creating a Safe Space in the Emergency Department. All communities deserve equal access to mental health services, but often the only alternative is the local emergency department. Tidelands Health leaders will describe how psychiatry consult is offered through the State Department of Mental Health Telehealth Collaborative for emergency department patients, and how they have partnered with the Medical University of South Carolina for routine telepsychiatry consults for hospitals and physician services. This podcast will also share how Tidelands Health took an existing space down adjacent to the emergency department in one of their hospitals and created a secure unit specifically designed for behavioral health patients. This new environment improves safety for patients and staff and provides a calmer environment for assessment than the hospital's ED. Lastly, Tidelands Health will discuss how they have participated in a county collaborative group to promote interagency coordination and community awareness of behavioral health resources in their community to help the behavioral health patient or their family access resources before emergency crisis care is necessary. Ashley, thank you so much for joining us today. And first, can you just tell me a little bit about yourself, your current role at Tidelands Health?
Yeah, thank you so much, Rebecca. I'm Ashley Capps, Associate Vice President, Nursing Operations. I joined Tidelands Health just about 5 years ago, and my areas of oversight include our emergency services, and I help lead our behavioral health efforts for the health system. My nursing background is adult critical care and emergency nursing, and so I've always been very passionate about this population in particular. While Tidelands Health does fall into that 45% of hospitals you mentioned that don't have behavioral health services, we certainly do care for behavioral health patients throughout our enterprise, not only in our emergency departments and our hospitals, but also in our physician practices. And so the needs of this patient population are very complex, and they're often further complicated by, gaps in social determinants of health and difficult to navigate national health system of care. And so collaboration and coordination to address this problem is just something that I've been very passionate about, particularly since moving into healthcare leadership.
Might I ask you to provide an overview of your collaboration with the State Department of Mental Health Telehealth Collaborative for the emergency department patients, and how you've partnered with the Medical University of South Carolina for routine telepsychiatry consults for hospitals and physician practices?
Sure. So the South Carolina Department of Mental Health Telehealth Collaborative consists of psychiatrists across our state, and they provide psychiatric consultation and recommendations via telehealth technology to emergency departments throughout the state and the hospitals. Patients and the psychiatrists connect via telehealth, audio, video equipment, and the evaluation is completed remotely, and then our emergency department clinicians are there to assist as needed. The psychiatrist then will make a recommendation for treatment and collaborate with our emergency physician to determine, what the next steps are for those patients. But despite these efforts to meet the current demand, patients sometimes still do have to wait for access to the services, and this program is only available to the emergency departments, the Department of Mental Health program. So outside of our emergency departments, we partnered with MUSC, Medical University of South Carolina, to provide psychiatric consults and recommendations for patients in our physician practices, in our ambulatory setting, as well as those that have been admitted into the hospital. This gives us access to experts that wouldn't have otherwise been available to our patients or our physicians, and has been really beneficial in closing that gap in access to care in the absence of clinicians and psychiatric services, as you mentioned, for the hospital system. And then getting these patients connected to the behavioral health psychiatry experts before they're in crisis is really a crucial component to proactively caring for this group. So once they're in crisis, they may have medical conditions that require hospitalization and stabilization prior to their mental health needs being addressed. And so if that's the case, again, we partner with Medical University of South Carolina to provide telehealth consultation in our hospital settings as well.
That's exceptional, Ashley. The prevention work that you're doing and the ability to provide integrated behavioral health care using telepsychiatry so that you can avoid the crisis and treat the whole person. I mentioned earlier, I talked about the designated safe space that you have created in your emergency department. What was the goal of creating it, and has it been achieved?
Well, certainly our priority at all times in any of our settings is to keep our patients, visitors, and our staff safe. And much like what is reported nationally, we have experienced an increase in behavioral events that involve these patients, and often those events do take place in our emergency departments. There's a lot of statistics out there that show that healthcare workers are significantly at higher risk than those in other industries, and so again, consistent with those trends, we see those events in our emergency department. So to address this particular issue, we took an existing space, redesigned it, and built out a secured unit that is adjacent to our emergency department that really took the unique needs of this population into consideration. So the space is very simple. It is a very calming and quiet environment, and the physical features of the space really have safety at top of mind. The unit is staffed with a registered nurse and a security officer at all times, and then, should the need arise based on patient acuity, we will add additional resources as needed. But in our busy main emergency department, staff and other patients were quite vulnerable when a behavioral health patient might escalate. And in this new space, the design and technologies are in place to really meet the patient's needs while also keeping the staff safe and promoting, the best possible environment for the situation.
That's wonderful. Have there been positive but unexpected consequences from this new space?
Well, certainly, I think that, we expected a safer environment for our patients, and we certainly hoped for a safer environment for our staff. But our nursing staff in particular do report that they feel safer and better equipped to respond appropriately to these patients. They do feel that it has reduced the number of events. The space has been operating for a short period of time now, but they certainly report feeling like they are better prepared and equipped to respond. The nursing staff also appreciate the immediate presence of security. Security is always close by in our emergency department, our hospital system, but in this new space, they are there at all times with the nurse. So I think patients respond better in this space that has a lot less stimulation, a lot, less noise. They're not subjected to all of the busy activity in the main emergency department. And so it lends itself to the patients being able to focus a bit more on staying calm and being still. But the space is much more conducive to the calming effects that this particular population will benefit from.
So by now, people listening to this podcast are probably wondering how can they convince their hospital or health system leadership to do something similar. How did you achieve that in terms of getting your hospital and health system leadership to support the creation of the safe space?
Well, our executive team and our board of trustees are certainly, committed to addressing the issue not only of workplace violence, but also being able to best care for these patients as with any patient population in the absence of a particular specialty. I mean, we're a community hospital system, and so there are a lot of specialty services that we don't offer, yet we certainly are committed to providing the best possible scenario for our community members. And so really where we started is laying out the space requirements and what that initial capital investment was going to look like, just so that we could really have a broad understanding of the scope of the project. And it was quite broad. But our leadership team, again, they fully committed those resources and were very engaged through the entire process. We started with an FMEA risk assessment. Hospitals will likely be familiar with those, not only of both of our emergency departments, but any of our areas where we might have a mental health, behavioral health patient, and where those patients might be, holding in our areas, awaiting the next level of care, and looked at systematically mitigating those risks. So taking each of those areas of opportunity and saying, how can we best support a safe environment for these patients? Because as a hospital system, that's our obligation, above all, to provide a safe physical environment of care, particularly for patients who are identified at risk for self-harm. So we worked through the physical space, and we worked through, again, that systematic risk assessment, addressing those issues. And then in a more holistic approach, we also looked at clinical practices and protocols and ensuring that those are evidence-driven, as well as some psychosocial support and stigma and awareness training for any staff that work with the behavioral health population, not only our clinicians, but also our support staff and security. And so really that holistic approach to caring for this population aligns very well with the mission and vision and values of our health system. And so I think it was easy for that executive team and our board to get behind this initiative, and they've certainly supported it wholeheartedly.
As this process has evolved, what would you do differently if you could go back in time?
That's a great question. Well, it was quite a lengthy process, as is typically the case with construction or capital investment in physical space. You've got to add some additional time to the baseline project. So with regard to the physical space, a lot of the lead times for the technology and hardware that we utilized in that designated space, they were quite extensive, in some cases several months. And so that did delay, our project timeline just a bit. So someone designing a space or putting a project together, that's certainly something to consider. And then, like I said, as we were working through some of those timeline constraints and working through the physical space, our team was concurrently looking at development of policies and best practices, protocols, standard work, because structure in the delivery of care is important with this particular patient population. So we really were trying to figure out how we could use the time productively and also best support this stabilization, this transition and stabilization time for these patients. As we mentioned, we're not providing inpatient psychiatric treatment during this time. So we still want the time to be positive and productive for patient outcomes. I think that with regards to what we would have done differently, I think it just would have been to build in a little more time with regard to expectations. We did come back to the executive and the board with a couple of delays in the necessary go-live time, the opening time. So you certainly hate to come back to the group and say it's not going to be what we predicted it to be. So perhaps building in a little more contingency in the timeline as a lesson learned.
I think many of us have been on projects where we wish we could have done just that. Managing expectations is always something that 20/20 hindsight sometimes can let you know how you should have done it better. But it sounds like you've been successful regardless. Last question. If you could change one thing, and just one thing, about our healthcare delivery system, views and response to behavioral health patients seeking care in the emergency department, what would it be?
Yeah, that really is a great question. I think that one of the opportunities that we have, particularly in our area and our community, has been identified with some of the collaborative work that we've done, is to recognize that we need to optimize the resources that we do have. We'll often cite a lack of providers or a lack of services, a lack of inpatient beds, for example, as a source of contention for caring for these patients. But I think that many of us within the interagency world realize that we have some resources that we're not best optimizing currently. And so I think that care coordination and collaboration among those agencies is just such a crucial component to success in promoting positive patient outcomes. So, I think in our previous podcast, in our first series, we mentioned some of the work that we did with our county collaborative, behavioral health collaborative. And so that team really works and meets to best understand each other, what our challenges and what our barriers are, and how, one agency can work with the other in order to promote those positive patient outcomes and really align care for these patients. And so I think collaboration and coordination among our agencies to really make our communities aware of what resources are out there and how we can best optimize what we do have is probably our greatest opportunity.
Ashley, thank you so much for sharing your insights, your experience, and inspiring others to go on this journey.
Thank you so much, Rebecca. It's been my pleasure.
If you'd like to learn more about the work that the American Hospital Association is doing on behavioral health, visit us at aha.org/behavioral health.